Okay, good afternoon. Thank you for the organizers for giving me the opportunity to present the work. It's also a poster, and thank you for the chairs of this session. And so I will present part of an analysis that we are doing with the PopTrans study. It's actually part of a master's dissertation for one of my students. And we'll start a little bit with the rationale. I wanted just to focus that access to PrEP in low and middle income countries remains very limited. And Brazil has one of the largest and oldest HIV treatment programs in the world, and will soon, very soon, integrate PrEP in the national public health system. Therefore, we explore PrEP awareness and willingness among transgender women in Northeast Brazil. It's one of the poorest areas of the country. As you know, Brazil is an enormous country with a pretty large inequalities, not only geographic, but in many other social, demographic, and structural issues. So this, as I was telling you, is part of the PopTrans project. It's a mixed method study. Drawing on two data sets, respondent-driven sampling, that I will present the data from the survey, semi-structured interview, we've been doing different analysis with this part of the study, and also a documentary. So a standardized questionnaire was used to collect quantitative data on several of social behavior variables. The data collection was pretty long, so RDS for this population, it's quite challenged. And after IRB approval and written informed consent, we started the study. So the individual RDS sampling weights to adjusted the parameter estimation procedures in order to consider recruitment bias were calculated using the RDS analyst program. And we used latent class analysis, LCR, to identify those willing to take PrEP from the following list of variables. We had all these variables in the questionnaire that the group from Rio, Beatriz and Valdileia, very gracious, let us use part of their questionnaire to investigate knowledge and awareness and willingness to use PrEP. So we have 7 different variables. You can see they're listed here, and we use that to do the latent class analysis. The parameters of the LCA, the prevalence of classes and probability of the response to the item were utilized to the description of the latent classes for the final model selection. And after the analysis, we identified 2 to 6 latent classes. They were analyzed, and the model chose to describe willingness to use PrEP. It was one with 2 latent classes that I will describe in a moment. And the model and the weighting of the RDS program, we used the RDS2 estimator, were transferred to the database for descriptive and multivariable analysis, and we use this data for all the epi analysis. So 2 latent classes were identified. Class 1, high willingness to use PrEP, and class 2, low willingness to use PrEP. And you can see here the LCA analysis, and I wanted to point it to you that low willingness to use PrEP represented 8.7% of our population. So a total among 127 transgender women were recruited, and I'll give you the descriptive of our population, but I wanted to point that 18.4%, only 18.4% were aware of PrEP. However, upon learning what PrEP is, the willingness to use was reassuring. And awareness was also low for most of the HIV prevention methods except for condom, and you see that in the next figure. But our population, most participants were young, Black over mixed race, had low income, had less than 11 years of education, reported high levels of gender-based discrimination, sex work throughout their lives, illicit drug use, previous HIV test, and inconsistent condom use in receptive anal intercourse with scheduled partners. And here you see that awareness of most of HIV prevention methods, it's quite low, except for condom. It's very similar to the study from the real group, but ours is even lower. So going to the findings, factors potentially associated with low willingness to use PrEP in bivariate analysis, and we chose to do this analysis because it's important to understand low willingness and what are the factors associated with low willingness, because high willingness was already high. And so we wanted to understand why some of the transgender women in the North States were not willing to use PrEP, as PrEP is going to be launched very soon in the public health system. So why are some of them don't want to use? I'm sorry. So age greater than 25 years, not of a black race, with a monthly income higher than $300, reporting use of illicit drugs, history of sex work, previous HIV test, inconsistent condom use in receptive anal intercourse, and knowledge of PEP were the factors associated in bivariate analysis. And going to multivariable analysis, you can see here that even though the point estimate for the odds ratio is greater than 1, because of the small sample size for some of these analyses, only here condom use with receptive anal sex with scheduled partner was the only significant of low willingness to use PrEP. And here just I describe what I just showed in the table. And so PrEP awareness was much lower in the SPOL area of Brazil than in the southern region, and the real group showed there was 61%. Access to PrEP still limited in Brazil, and work needs to be done to increase the PrEP awareness, as well as implementation studies to design for transgender women, addressing their social disparities and needs are urgently to prove its efficacy when available in the public health system. So for most of the transgender women, PrEP was considered a very important HIV prevention tool in our area, and social and structural behavior and clinical factors contribute to the retention in PrEP care. So this is our group. I would like to acknowledge the support of a Brazilian Department of STD, HIV, AIDS, and biohepatitis, and this is the cover of our documentary. Thank you.
Thanks. So you can join us actually on the here.
Oh, okay.
Okay, on the panel. So it's my pleasure now to introduce Dr. Truong, who is Associate Professor of Medicine at the UCSF, United States of America, and I really ask speakers to stick on time so that we can have discussion time at the end. It's really important. Thank you.
I'll try my best. Good afternoon. On behalf of my co-authors at UCSF and the San Francisco Department of Public Health, I would like to thank the conference organizers for the opportunity to present the findings from our study examining HIV transmission risk of persons closely linked to trans women in transmission clusters. Worldwide, HIV prevalence among trans women is 50 times higher than in the general adult population. In many surveillance systems and surveys, trans women and their male partners are frequently classified as men who have sex with men. This is irrespective of their gender identity and sexual orientation. We examined phylogenetic transmission clusters to gain insight on sexual and needle-sharing networks as potential sources of HIV risk among trans women. San Francisco residents diagnosed with HIV between years of 2000 and 2015 who are in care at public facilities and who have had available viral Pol sequences were included in this analysis. Transmission clusters were with 2 or more cases were identified using the definitions of bootstrap values greater than or equal to 90% and a mean pairwise genetic distance of less than or equal to 0.025%. Trans women comprised 275 of the 5,200 cases with viral sequences and were present in 70 of the 563 transmission clusters identified. Of the 86 trans women in clusters, 51% reported an injection risk. We describe the clusters by the HIV risk classification of persons within each cluster. Of the 70 clusters of trans women, men who have sex with men who inject drugs were present in 47% of the clusters, non-MSM PWID were in 26%, MSM were in 54%, and heterosexual men were in 1% of the clusters. When HIV risk was re-examined under the assumption that men closely linked to trans women in clusters were not MSM, the profile of clusters shifted dramatically. MSM PWID were now present in 16% of clusters, non-MSM PWID were in 57%, MSM were in 16%, and heterosexual men were now in 47% of the clusters. This revised profile was similar to that observed among the 130 clusters with cis women, where MSM PWID were present in 27% of clusters, non-MSM PWID were in 41%, MSM were in 28%, and heterosexual men were in 58% of the clusters. In conclusion, the phylogenetic data suggest a high potential for HIV transmission between trans women and persons who inject drugs. The classification of male sexual partners of trans women as MSM may be obscuring their true sexual networks. There is recognition that trans women should be considered based on their gender identity rather than their sex of birth for health services and research. These phylogenetic insights that we presented today strengthen the inference that the research findings and HIV prevention programs for MSM may not be applicable to trans women or their sexual partners. Thank you for your attention.
Thank you so much, Dr. Trong. I would like to invite our third speaker, Dr. Rashmi Ramasarin from Thailand.
Thank you. I would like to thank the organizers for giving us an opportunity to present our work here today. So transgender women have a risk of HIV, which is almost 50 times higher compared to the general population. And in Thailand, about half of all new infections occur in transgender women and MSM. The HIV prevalence among Thai transgender women is estimated to be between 10 and 15%. So prevention efforts targeting this group are needed, and to inform these efforts, we wanted to assess the self-perceived HIV risk, actual HIV risk, and HIV knowledge among Thai transgender women in the community-based test and treat study at enrollment. So the community-based test and treat study is a prospective observational cohort study in Thailand, which aims to assess the feasibility of community-based test and treat strategies among transgender women and MSM to increase the uptake of HIV services. This study takes place in 6 community-based organizations in 4 provinces in Thailand. And the organizations are based in the community and also led by the community, which means that the cascade of reach, recruit, test, counsel, and link to care are all done by trained community health workers who are themselves members of key populations. So within this study, we looked at Thai transgender women, and everyone completed a self-administered questionnaire prior to HIV testing in the study. And the questionnaire was used to assess the HIV risk perception and risk behaviors in the last 6 months, as well as HIV knowledge, for which participants were asked to identify which statements were correct on HIV transmission and HIV prevention. HIV testing was performed as well as STI screening. So there's a lot more information on the poster, but I wanted to point out here, between May 2015 and September 2016, 726 transgender women completed the self-perceived risk questionnaire. Their mean age was 26 years old, and 53% of them were aged between 18 and 25. 33% reported to be a service worker, and the HIV prevalence in this group was 9%, while a third had any STI at any compartment. So that includes oropharyngeal, anal, as well as urethral. When asked about their self-perceived risk in the last 6 months, 12% reported that they did not perceive themselves to be at any risk at all. 40% perceived their risk to be mild, 30% perceived their risk to be moderate, and 18% perceived their risk to be high. What I would like to point out here is that the knowledge on HIV transmission and prevention was not different in these 4 groups. And the risk behavior in the last 6 months, as reported by multiple sex partners, inconsistent condom use, non-intravenous drug use, and engaging in group sex, was actually higher with a higher level of perceived risk. However, and that's the focus here, of those 90 women who did not think that they were at any risk, almost 30% reported multiple sex partners in the last 6 months. A little over 60% did not use condoms consistently. A third reported non-intravenous drug use, and 2% engaged in group sex. Of those who perceived their risk to be mild, it was even higher, with almost half having multiple sex partners, almost 80% not using consistent condoms in the last 6 months, non-intravenous drug use in about a third, and 10% engaging in group sex. So we found that Thai transgender women with lower self-perceived risk, as reported by themselves, had actually high-risk behavior, while knowledge on HIV prevention and transmission were similar. Self-perceived HIV risk is essential to reduce risk behavior and increase the uptake of HIV testing, and low self-perceived HIV risk has also been associated with a lower uptake of and adherence to PrEP. So HIV prevention services that focus on improving the knowledge alone may be insufficient to modify the assessment of self-perceived risk, and factors that can improve the assessment of risk should be explored so we can target these high-risk transgender women. I would like to thank my co-authors, the funders of the study, and all the staff and participants at the CBOs.
Thanks a lot, and thanks also for sticking on the time. So the next speaker is Dr. Tonio Putea, who is an assistant professor in the Department of Epidemiology at Johns Hopkins Bloomer School of Public Health, and the presentation will be engaging transgender women of color in HIV prevention. Thank you.
Thank you. I'm very excited to be here and to speak with you and see familiar faces, including one of my colleagues who worked on the study, Nini Amama, so I wanted to wave and say she can correct anything that I get wrong. I have 3 slides, and I'm going to try not to talk too fast for you to hear me, but the poster is outside. This was a study that was conducted in Baltimore, Maryland, and Washington, D.C. We called it the Strobe Study after many, 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 many weeks of trying to find a name, supporting trans research and opportunities in Baltimore and D.C. environment. Our goal was really to explore, quantify, and find a response to the burden of HIV. The previous presenters have already talked about what we know about the heavy burden of HIV among transgender women. We wanted to understand what that burden was locally and figure out what the best way we could respond. So it was basically a 2-phase study. We started with qualitative formative research. We interviewed 12 key informants and asked them about what were the key issues in the trans community that we needed to make sure we included in the survey, and questions about survey design, recruitment, and things like that. And several of those key informants were trans people. And then afterwards, we brought some of that data to focus group discussions with transgender women of color in the Baltimore community. We later expanded to DC, and asked them about some of the questions, how we worded them, and things like that. And then we developed the quantitative survey, interviewed and did rapid HIV testing with 200 transgender women, and then brought that data together to synthesize and interpret it. And I will say that we just finished data collection at the end of May, so we are still working very hard to get it all together, so we don't have everything right now. The participants, the average age was about 38. In terms of women of color, for those not from the United States, we included anybody who didn't identify as white, so mixed-race folks, as well as Black, African American, or Latina and Hispanic, and you can see the breakdown there. The majority of participants had public health insurance, not private insurance. As you can see, there was a lot of instability in housing. Income was generally below the poverty level, and a lot of unemployment as well. I think what was most surprising to us was the incredibly high HIV prevalence, with over half of the participants in the study, 55% of the participants having HIV, testing HIV positive. In terms of the study results, in terms of the things that came through as themes in the qualitative interviews, you can see listed there that violence is really a priority in the community. There's been a growing amount of publicity in the United States around the violence, particularly targeting transgender women of color. And one of the key informants said we need to be aware, because there have been so many murders and so much violence, that HIV may be less of a priority in the community than violence is. And in fact, other key informants talked about how much there was so much focus on HIV that it sometimes scares people away. They're sort of tired of hearing about HIV. There's a lot of HIV stigma still in the community. People talked about distrust of medical establishments and fear of being used as guinea pigs and being given pills. And then a desire really for holistic support, to be seen as in supporting their journey as women and not so much focusing on them as a person with or without HIV. In the quantitative results, we saw high awareness of PrEP, which is consistent with a lot of the efforts that have been undertaken in both of the cities to raise awareness. However, we saw incredibly low uptake. About 18% of people were actually taking PrEP. Then when we asked for people who did not have HIV or didn't know their status, if they'd be willing to take PrEP, it was high. So I think that actually speaks to a disconnect between what we think we're offering people when we offer them PrEP services and what people perceive us to be offering them. When there's a high willingness to say, hey, are you willing to take a pill to prevent HIV? People say yes, but then in terms of on the ground, and when they're aware of what's actually being offered, there's less uptake. So hopefully we can talk about that. And in terms of people living with HIV, there was a high engagement and care among the people who participated in the study, with most people having had a visit in the last 12 months, having taken ART. But there was also a high percentage of people, 57%, who'd had ART interruptions, and 39% who had ever had a time where they couldn't get their antiretroviral agency. So even in a country with lots of resources and theoretical availability of ART, people still have treatment interruptions and difficulty accessing care. But for those who could, you can see the last viral load was undetectable in 82%. This is my last slide, and this is the recommendations that came forward through the key informant interviews. And they recommended, in terms of engaging trans people in research and engaging trans people in HIV-related care, we really need to focus on embedding the HIV services within programs that are responsive to what the community actually needs. So I would say violence prevention wasn't listed specifically, but I would add that. Job readiness programs, mental health support, housing, those types of issues, providing gender-affirming care alongside HIV services, offering HIV services at places where transgender women of color already go, where they already feel comfortable and safe in communities. Ensuring that when you offer services that the staff is trained, the entire staff, including healthcare providers, administrative staff, security staff, in transgender competent care, hiring transgender women of color to lead programs. And I highlighted lead because I think there's a tendency to hire people to do particular parts of the program, but not to really lead. And to tailor the services, outreach, and advertising to the community needs. So thank you. Hopefully I was within my 5 minutes. I want to thank my colleagues and the Center for AIDS Research, specifically at Hopkins, that funded the study. Thank you.
Thank you so much for your presentation. It's always a pleasure to hear you. So our first speaker is Dr. Xin He from Cambodia, Director of Canna Center for Population Health Research in Cambodia and Adjunct Associate Professor at Center for Global Health Research of Touro University of California.
Good afternoon, everyone, and thank you, Chair, for the nice introductions. Let me try to make the best use of the 5 minutes to tell you something about our studies exploring factors associated with HIV infections among trans women in Cambodia. These results were from our recent national integrated biologicals and behavioral surveys in the countries. As the previous speaker talked about, transgender women remain of great challenges in HIV programs. They have long been known to be at high risk for HIV infections with poor access to intervention programs and are not well understood compared to the general population due to their hidden and stigmatized natures. According to a literature review conducted by Barrals and the team, published in The Lancet in 2013, as you could see in the slides, globally, the HIV prevalence among trans women is around 19%, with a lower at 17.7% among trans women living in low and middle income countries, and a little bit higher in the countries with higher incomes at 21.6%. And the map also show very clearly that there are large gaps in terms of HIV, the information, data regarding HIV prevalence and risk factors among trans women across the globe, as you could see in the white colors. So the objective of this study was to explore HIV prevalence and examine risk factors for HIV infections among trans women in Cambodia. This study was conducted in between December 2015 to February 2016 in the capital city of Phnom Penh and 12 provinces, with a sample of 1,375 recruited through respondent-driven sampling. An individual would be included in the study if they were transgender women by the definition set by the research team using the definition from UNAIDS. If they were aged 18 years old and older and they were currently sexually active, defined by having sex with at least one man in the past 12 months, and if they were able and willing to provide written conformed consent before the data collections. This study was approved by the National Ethics Committee for Health Research, and informed consent were obtained from each respondent, and we strictly protected their privacy and confidentialities of the participants. Both multivariate and bivariate and multivariate analysis were conducted. I'll show you briefly about the result, and this is the result from the multivariate logistic regressions after adjusting for others potential covariates. So we found that HIV, the prevalence of HIV was significantly higher among trans women living in urban areas, in older age group of 25% of 34 and older compared to those younger than 25, those with lower level of formal education, and those who had stronger women identity, defined as dressing or expressing or dressing up as a woman all the time, compared to those who dressing up as a women not all the time. And the prevalence was also significantly higher among those who reported cell-injected hormone cell injections, and also among those who reported having at least one symptoms of sexually transmitted infections, and among those who reported using online services that were developed for specifically for transgender women in the countries. So in conclusions, despite the success of the country in bringing down the HIV prevalence in the general population from about 2% in the late 1990s to only 0.3% in 2014, HIV prevalence among transgender women remain pretty high at 5.9%, but as you could see, it's still lower than many other countries in the world. So to control the epidemic of HIV among these people who are regarded as one of the key population in the countries, the priority should be provided to those transgender women who are older, living in urban areas with lower level of formal educations, and who were expressing stronger feminine identities. And those who, education should also be provided to improve or to promote the safetiness of the hormone injections among these population. And preventions and screening and treatment for sexually transmitted infections should be reinforced. I would like to thank our funders that include the PEPFAR through USAID Cambodia and the Global Fund to Fight AIDS and Tuberculosis and Malaria who funded these studies, and our co-authors as well as all the collaborators and our participants in the studies that made these, who have made this study possible and successful. Thank you.
Thanks a lot. So the next speaker is Dr. Carmen Logi, who is Assistant Professor at the Factor Inventage Faculty of Social Work, University of Toronto. And she's going to talk about the prevalence and correlates of police harassment among transgender women in Jamaica and the implication for HIV prevention and care. Thank you.
Thank you. I want to acknowledge my co-authors, in particular my colleagues from Jamaica AIDS Support for Life, located in Kingston, Ocho Rios, and Montego Bay, Jamaica, as well as Canadian Institutes of Health Research, or CHR, for funding. And so Jamaica is widely known for homophobia and criminalization of homosexuality. The general prevalence of HIV is approximately 1%, and we know that it's higher among men who have sex with men. However, there's been, to our knowledge, no studies focused on trans women specifically in Jamaica. And there's less known also about what are the experiences of police harassment among trans women in contexts where homosexuality is criminalized. And so what I'm presenting on is the second phase of a mixed method study. So this study was conducted from 2013 to 2016. The first phase was qualitative, and as part of that phase, we conducted 20 in-depth interviews with trans women, and we had a team of peer research assistants, which involved trans women as well, and we had a focus group. Across every single interview and the focus group, violence was a common theme, both community violence and police violence. So oftentimes when trans women would experience violence in the community and they would go to seek help from the police would then either verbally or physically or sexually abuse the woman for trying to report the violence. So in our quantitative study, we decided to ask questions around police violence. So this specific analysis looks at factors associated with experiencing police harassment, verbal, physical, or sexual, perceived to be due to their gender identity. So we surveyed 137 trans women across the 3 sites. The mean age was 24. Most had high school education. The mean monthly income was $123 US. And we found really high rates of HIV, 25% among trans women. We also found 44% reported experiencing police harassment, and 16% had been incarcerated for what they perceived to be due to their gender identity. And half of the population had sex work involvement in the past 12 months. So we then conducted unadjusted and adjusted logistic regression analyses to look at factors associated with reporting police harassment. And you can see HIV positive women, women involved in sex work, women with lower levels of social support and higher depression, and women experiencing food insecurity and unstable housing, as well as women who reported higher perceived stigma, so awareness of negative community norms around trans women, and enacted trans stigma, so actual experiences of discrimination and mistreatment due to gender identity, all were associated with higher likelihood of reporting police harassment. And in adjusted analyses, trans women living with HIV were 3 times more likely to report police harassment, and trans women who experienced enacted trans stigma were also more likely to report police harassment. And so while the directionality cannot be ascertained between police harassment and HIV vulnerabilities because of the cross-sectional nature of the study, so we don't actually know were trans women living with HIV more likely to experience poverty and perhaps precarious housing and employment, which would increase contact with police, Or did police harassment result in less uptake of HIV prevention services and access to health care, which then increased likelihood of HIV acquisition? So we're actually planning for some longitudinal studies to better explore the social determinants of HIV vulnerabilities in this population. And if you're interested in our findings, you can email me. We have 2 articles that just came out this year in the Journal of the International AIDS Society, one on looking at sex work involvement, the other on HIV testing, which is from our qualitative phase. And in the fall, we had a study come out in AIDS patient care on the prevalence and correlates of HIV infection. Thank you.
Thank you for your wonderful presentation, Dr. Carmen. And I would like to invite our last speaker, Dr. Beatriz Greenstein from Brazil, Fiocruz, Brazil.
How can I put the presentation here?
Escape, and then you can just put your. Yeah, you are.
So good afternoon. First of all, I would like to thank the conference for the opportunity to present our results. I would like to also acknowledge my co-authors and sponsors. And here are my disclosures. So PrEP Brazil is the first demonstration study for PrEP-naive MSM and transgender women in Latin America. Here we will report the week 48 results on PrEP retention, engagement, and adherence, HIV and STI incidence, and sexual behavior. PrEP Brazil was conducted in 3 sites in Rio de Janeiro and São Paulo, and enrollment was initiated in April 2014. Dried blood spots for tenofovir diphosphate and FTC triphosphate measurements were collected at weeks 4 and 48 for all participants and at all study visits for young MSM and transgender women, and were processed at Dr. Pete Anderson's lab at University of Colorado. At each visit, participants were tested for HIV and syphilis. CASI was used to assess sexual risk and substance use. Prevalence of rectal chlamydia and gonorrhea were assessed at enrollment and at week 48. And the pilot sub-study of interactive text messages, SMS, was offered to all participants using a model adapted from the WellTel study. Individuals who agreed to participate, that was the majority, were randomized 1-to-1 to the intervention. PrEP retention was defined as the attendance of the week 48 visit, irrespective of attendance to other study visits. PrEP engagement was an ordinal 5-level variable combining presence in the study visit and drug levels. Thus, the worst engagement level was a missing visit. The second level was attending the visit and having no detectable drugs. The third level was tenofovir DP levels consistent with less than 2 doses a week. The fourth level compatible with 2 to 3 doses a week. And the fifth level with 4 or more doses a week. 450 participants initiated PrEP, of which 83% were retained through the study. Of note, 4.5% of participants were trans women, in total 25. The bar on the left shows PrEP engagement for the entire study population. At week 48, 70% missed the visit, 5% had undetectable drug levels, 4% had levels consistent with less than 2 doses a week, 12% had levels consistent with 2 to 3 doses a week, and 62% had levels consistent with 4 or more doses a week. Overall, 74% of the study population retained had protective levels consistent with more than 4 doses a week. PrEP engagement over time is shown in the figure on the right for young MSM and on the top and for transgender women on the bottom. Among young participants, the percentage achieving more than 4 doses a week decreased over time from 78% at week 4 to 59% at week 48, and this was statistically significant. Among transgender women, the percentage with protective levels varied from 74% at week 4 to 62% at week 48, and this was not a non-significant trend. Although drug levels between MSM and transgender women were not different at week 4, drug exposure decreased during follow-up for transgender women. Nevertheless, the majority of transgender women had a protective, meaning more than 4 doses a week, a protective level for the first half of the study, and more than half of the transgender participants persisted with protective levels throughout the study. The table on the bottom shows the results of the final logistic regression models that were adjusted for site location. When considering all participants, a higher adjusted odds of achieving protective levels was observed among those who had protective levels at week 4, who reported sex with HIV-infected partners, and who used stimulants. For young participants, Black race and having a steady partner were shown to decrease the odds of achieving protective levels, while more schooling and receiving text messages doubled the odds of achieving protective levels. The figure on the left shows that for the overall population, the percentage of participants reporting condomless receptive anal sex with the last 3 partners varied from 45% at enrollment to 49% at week 48. And this was exactly the same distribution for MSM and transgender women. On the bottom plot, we see that the mean number of sexual partners in the prior 3 months decreased from 11.4 at enrollment to 8.3 at week 48. And this was also the same trend for transgender participants. 2 individuals seroconverted during follow-up for an HIV incidence rate of 0.52 infections per 100 person years, both had undetectable tenofovir levels at seroconversion. Syphilis incidence was high, reaching 9 per 100 person years. Prevalence of rectal chlamydia ranged from 8% at enrollment to 7.7% at week 48, while the prevalence for rectal gonorrhea ranged from 5% to 3.7%. In conclusion, our results show high levels of retention and adherence to PrEP, corroborating PrEP's feasibility in a real-world setting of a middle-income country. Moreover, sexual behavior and STI incidence remained stable over time, suggesting a lack of risk compensation in this population. Although PrEP awareness among trans women was shown to be low in another survey we did, around 24% in Rio de Janeiro, over 90% of those participants in this survey would use PrEP if available for free. So demand building and community education are critically important steps for PrEP scale-up among transgender women in our setting, as PrEP has become now a public health policy in Brazil. This tailored study for transgender women was designed by our team and will be initiated next week, and we will enroll a new cohort of 120 trans women, and we will have also a nested PK study to assess drug-drug interactions. I would like to thank you very much for your attention, thank all my team and all the study participants.
Thank you so much, Dr. Beatriz, for showing us this important data. So now we have 10 minutes left for some questions. We're going to have the 2 questions and then the answers, okay? Okay. Please.
He's coming.
If there is no question,
There is no question?
He's walking to the microphone right now.
Okay.
Right. This is for Dr. Trong. I thought your study was fascinating in terms of redefining who transgender women's partners are. But it struck me while I was listening that it was doing more than that. It was actually uncovering, as it were, a new population of men, possibly, who may themselves have high HIV prevalence. We don't know. But it kind of only makes sense, the sky-high HIV rates you see in transgender women, in terms of what the HIV prevalence must be in the men who are having sex with them. So is this a distinct population of men, and should we be looking to see who they are? And the other thing that occurs to me is, of course, there's a lot about violence against transgender women. Well, maybe we need to research the perpetrators of this violence too.
Yes, Gus, thank you for your question. It is very interesting. I think that sort of the impetus for doing this analysis was the questions like, why are there really no heterosexual men in San Francisco with HIV? Based on sort of the surveillance data, the numbers were so low, but we see that there are heterosexual women becoming infected, and so that's kind of what prompted looking at this analysis. These data definitely are going to lead us towards following this line of research and looking at this group more closely, and this may be contributing sort of the questions like, where are the men, right? Finding the men. So, thank you.
Can I say something too?
So we ask you for introduce yourself at first, and then make your question, please.
Hi, everyone. I'm Erin Wilson. I work at the Health Department in San Francisco. Amazing presentations. Thank you so much. I had a couple questions. One, Beatriz, I wonder if you could talk a little bit about your retention. It's really extraordinary. And I think it would be great to hear more about what you're doing to keep folks engaged in Trans Preparadas. And then Inez, I was also curious if you could just tell us a little bit about the HIV prevention services. You talked about integrating PrEP into what's already existing, and I'm just curious what folks already have access to locally. And then just on the partner question, we're hoping to do research with partners in San Francisco soon, so stay tuned.
So, thanks, Erin, for your question. So when we started all this work, so as this is a demonstration study, we didn't recruit anyone. However, given the information we had from the community that the level of literacy among transgender women was so low, we have in our team, 3 dedicated transgender women community educators. So they went to the community and did groups of interacting with them and explaining what is PrEP and discussing risk. That's another big problem, is the risk discussion, risk perception, and the need not to talk about risk. And so the peer education was a very successful way to bring them, and also helped a lot with retaining them. So retention was not different between the groups of MSM and transgender women. And one important thing I wanted to add is that at that time, unfortunately, we didn't have hormone provision at our site. So this was possible even without having hormone provision at the site level.
Can I just, before giving the floor to Ines, one question, Beatrice. Did you talk only about PrEP when you went to the community, or did you talk more widely about prevention in general?
Yes, I think that's an important point. We never talk only about PrEP, but of course, what we have available is condoms. Now we have PrEP. Condoms is something that they know about, and they really don't have the understanding about PrEP. So we take the most of the time bringing the concept of PrEP in a way that it is framed in a way that for empowerment and to have the opportunity to get to stay healthy. So the message is, we don't talk about HIV most of the time because really they don't want us to talk about HIV and disease, and they feel as they are vectors. So we don't touch the issue of HIV. Yeah. We just talk about staying healthy and have the power to protect yourself. Yeah, that's the message.
I didn't mean condom. I mean vaccination, STIs, much more. Yeah.
Yes.
Combination.
The combination, yeah.
Thank you, Erin. So in Bahia, in northeast of Brazil, in terms of healthcare for transgender women, it's just starting. We are very late compared to other cities like São Paulo or Uberlândia. But this is like more general in Brazil. Not many states, not many capital cities have transgender care. in place. So condoms, of course, so as you saw, awareness was high for condom. That was the only one. And even PrEP, not a lot of transgender women knows where to go to search for PrEP. So the information of PrEP has been in Brazil for 10 years now, completed 10 years, and not a lot of them know even what PrEP is. So I think we have a lot of work to do in Brazil, and depending on the area, more work because of, as I said, healthcare and even a broader care for transgender women is just starting.
Yes, good afternoon. François Berdugo from France. Thanks for your presentations. It was not exactly on the scope of your presentations, but I have a question about transgender men, and specifically the subpopulation of transgender men who have sex with men. Because we know that globally the HIV prevalence is very low among transgender men, but there is specifically this subpopulation of gays and MSMs, and I would like to know if you got some data about that through your work, or if you have any comment in addition to what you already said. Thanks.
Tonya, you want to get
How did I get that question? So last year we presented a poster that was a global systematic review of HIV among trans populations, and there was a subset of that data looking at HIV among trans men who have sex with men. What we found is that most of that data came from North America. So there is a lack of global data among trans men who have sex with men in other countries, and all of you fabulous researchers here can fill that, I think, could work harder to fill that gap and get more information.
Any question? If not, I'm going to ask. Do you have a question, Alicia? No. Go on. Oh, I can ask a question. Now, I wanted a question. A question I wanted to ask regarding actually the presentation about Carmen, actually. How you explain the association with HIV and police harassment? Can you a little bit? Is it a a confounding factor, you think, or it is a real association actually?
Ines, yeah. I wanted to add, Carmen, if you did a more stratified analysis looking, who are these HIV positive women? Who are they? What other factors they have? What are sort of the structural filters or very large, high percent of discrimination? So I think if you can also comment on that,
Yes, so we did do a specific analysis on correlates of HIV infection, and that is in AIDS patient care and STDs in the fall, where we did find that discrimination and stigma and absolute homelessness were all associated with HIV infection. With regards to the first question, I think that police harassment is sort of a proxy for human rights violations. And so there's been a lot of literature describing how human rights violations contribute to HIV vulnerabilities through reducing access to simple things such as even condoms. And in the qualitative data with the trans women, there is some extreme discrimination in accessing housing. So there's a lot of absolute homelessness, and there's also a lot of discrimination accessing any health care. So people who've once gotten tested are actually less likely to get tested again because of negative experiences in the healthcare system. So I think with regards to police harassment, there's not maybe a direct relationship to HIV infection, but I think that it's a proxy for understanding the multiple vulnerabilities that I discussed that were associated with police harassment: food and housing insecurity, enacted and perceived trans stigma, and depression and sexual risk. Just paint a picture of the harmful effect of human rights violations. And I forgot, I was kicking myself. I said, I forgot to talk about the implications. So we need to decriminalize homosexuality and have non-discrimination based on gender identity and sexual orientation in every country. So that was my last sentence I had forgotten to say, so thank you for asking me that.
So as Dr. Tonya said, we need to have holistic support and holistic approaches to transgender population. It's very important because just behavioral, just biological issues is not sufficient. We have I would like to highlight this phrase, holistic support and approaches to transgender population around the world. So we would like to thank you for being here, and I would like to thank IAS for allowing me to be this part of this session. For me as a transgender woman, it's very important to be here today. As a pharmacist, as a transgender woman, I would like to thank IAS for allowing me to be part of this session. Thank you so much.